All right, good evening, everyone. My name is Dr. Tim Lubenow. I'm an anesthesiologist and pain physician in Chicago. Tonight is the Aspen webinar on interpretation of the lumbar MRI. I always view this as one of the most important pieces of information that a interventional pain physician needs to have command of in order to make wise decisions about doing different interventional procedures. This particular webinar is being hosted by the Aspen Fellows and Young Innovators Committee, of which I'm a co-chair. Joining me tonight as co-moderators are my co-chairs of this committee, Dr. Yusur Ibrahim and Dr. Danielle Pak. Dr. Ibrahim, Dr. Pak, could you please introduce yourself and tell us where you're from?
Thank you for the introduction, Dr. Lubenow. Welcome, everybody. My name is Yusur Ibrahim. I'm an interventional pain physician practicing out of Wisconsin. Thank you all for making the time for being us tonight. I'm sure whether this is new material or a refresher for you all, you will find this to be a very beneficial webinar. I'm going to pass it along to my co-moderator, Dr. Pak, who will introduce our panelists.
Thanks, Dr. Ibrahim. As she mentioned, my name is Dan Pak, and I'm on faculty at the University of Texas in Houston. And really appreciate you all joining us tonight. I think as spine interventionalists, we have more treatment tools at our disposal more than ever. And one fundamental skill that is absolutely essential to have is the ability to read your own images, particularly MRI. So I would say gone is the day where you can just read the radiology report and just do your procedure. So that's what we're going to focus on for the next 45 minutes or so. We have three really excellent panelists to help us discuss the subject matter. We have Dr. Carla Samaniego from UT Houston, Dr. Robin Mata from Rush, and also Dr. Jordan Italiano from the Cleveland Clinic. So with that, I'll hand it over to Dr. Samaniego, who will kick off our discussion and talk about MRI basics. Dr. Samaniego.
Thanks for the introduction. Hi, everyone. I'm Dr. Carla Samaniego. I'm an anesthesiologist and the current pain fellow at UT Health Houston. And today I'll be covering basic overview of magnetic resonance imaging and lumbar spine anatomy. So to capture an image, the MRI system uses strong magnets, gradient fields, and radio frequency waves to localize and characterize tissues based on the amount and state of hydrogen atoms present. Imaging is based on the movement of these hydrogen atoms in the magnetic field. So the energy emitted by these atoms in the field sends a signal to a computer. This signal then gets converted into an image, and images are typically taken in 4mm slices. Next slide, please. So when a person is placed in a strong magnetic field, like an MRI scanner, this makes the hydrogen ions in tissues to align. This uniform alignment creates a magnetic vector oriented along the axis of the MRI scanner. And when additional energy in the form of a radio wave is added, the magnetic vector is deflected. And when the radio frequency is turned off, the magnetic vector returns to its resting state, or in other words, the hydrogen ions relax to their native form and emit tiny radio frequency signals that are used to create the magnetic resonance images. So in summary, the MRI signal is a complex function of concentration of deflected normal hydrogen ions, buildup and relaxation times of the magnetic field, flow or motion within the sample, and the magnetic resonance sequence protocol, which we'll discuss in a later slide. So MRIs have really excellent soft tissue contrast resolution, and the multiplanar tomographic capability make it very versatile and useful as a diagnostic imaging modality for spinal disorders. They provide a wide field of view with excellent definition of tissue types such as bone marrow, muscle, ligament, disc material, and nerve roots. It can also detect inflammatory change, edema, hyperemia, such as seeing blood in the epidural space, and evaluation of medullary bone with the MRI is excellent. And it's really good with osseous conditions that result in marrow edema or marrow replacement. So when you're identifying metastatic disease and myeloma, and it also has greater specificity than CT when characterizing the age or acuity of fractures. And then strong contraindications, as we all know, are related to the really strong magnetic field that's required for the imaging. So patients with cardiac pacemakers, metallic foreign bodies, or specific metallic implants can't be evaluated. For patients with cardiac pacemakers, there's a risk of it being disabled or reprogrammed, or the leads being repositioned by the magnetic field. Metallic implants, such as older cerebral aneurysm clips, can be displaced by the magnetic field, which would be catastrophic. And then while MRIs are invaluable, in helping us diagnose and treat patient pathologies, abnormal imaging findings alone shouldn't prompt you to perform invasive treatments. So systematic review in 2015 involving over 3,000 asymptomatic patients or patients who had no low back pain showed a high prevalence of abnormal MRI findings, which only increased with age. So for disc degeneration, you see among 20-year-olds, 37% had signs of this, and for 80-year-olds, 96% had signs of disc degeneration, yet had no low back pain. And then same thing with disc bulge. 20-year-olds had 30% signs of disc bulge, and 80-year-olds, 84% of them had signs of disc bulging. Next slide, please. So the two basic MRI modalities are the T1 and T2 weighted images. T1 weighting provides excellent anatomical delineation, and in general, high signal intensity on T1 represents fat, such as fatty bone marrow or the subcutaneous fat would be really bright, versus the low signal intensity represents fluid, which you would see as dark CSF. The bone marrow edema would be dark, and the normal nucleus pulposus would be dark. T2 weighting, on the other hand, while the fat-containing structures are still bright, they're not as bright as on T1 when you're comparing them to the fluid-containing structures like the CSF, edema, and inflammation, which would all be hyper-intense. And fat is typically bright on T2 weighting, but another popular modality is the short tau inversion recovery, or the STIR sequence, which is a T2 weighted sequence with fat suppression, and that's especially useful for detecting edema. Next slide, please. So, okay, here you can see the T2 and T1 weighted images side by side. On the left, you can see that the CSF is hyper intense and very bright compared to the T1. You can also appreciate the that on the T2 image on the left, the intervertebral discs, there are signs of hyper intensity, which demonstrates the healthy saturation and fluid that you would see in the healthy discs. And then for the level at the L5S1, you see edema that's better demonstrated when looking on the T2 compared to the T1 weighted image. Next slide, please. And then here, the T2 and T1 weighted images on a sagittal view, when comparing them side by side, you can really see how, on the left in the T2 weighted image, how bright that fecal sac is. Okay, next slide. Okay. So another really important thing to discuss is comparing imaging side by side, especially the T2 weighted axial and sagittal views, comparing them side by side. And that's really important when we want to, really make sure what level we're working at. So for instance, when you're scrolling through the sagittal view or the axial view, you want to know for sure what level you're working at, because you don't want to risk incorrectly identifying a pathology at the wrong level, or potentially planning an invasive procedure at the wrong level. So here is an example of the main tools that we typically use. So for measurements, the measurement tool is really excellent. Is really important for making a diagnosis. For example, if you're measuring out the ligamentum flavum and you measure it out and it's greater than 3 millimeters, typically that would demonstrate hypertrophy. And it's also a good tool when you're planning your procedures. So if you want to measure the diameter of the pedicle before performing a kyphoplasty, or if you want to measure the depth of the epidural to the epidural space before you're performing an ESI. And then also right here, when you click on that little man with the two arrows going in different directions, that puts that yellow cursor that we typically see cutting across either sagittal or axial view. And again, that way when you're scrolling through the sagittal and axial view side by side, you really know what level you're working at. Okay, so in this example, you have that yellow cursor cutting through the axial view, so that when you're scrolling through the sagittal view on the left, you're able to know if you're on the left side or the right side, or when you're right at the midline. Next slide, please. And then in this example, you have the yellow cursor cutting through the sagittal view. So when you're scrolling through the axial view on the right, you know exactly what level you're viewing. Again, and this would avoid potentially misdiagnosing a certain level as being the place that you need to intervene out. Okay, next slide, please. Okay, so now to review basic anatomy. Here in this sagittal view, you can see the neuroforamen, the hyperintensities just in the posterior aspect of the vertebral bodies, and some of them you can also note the nerve roots and the hypointensities, and then you can kind of make out the facet joints as well. Next slide, please. And then this is a really good sagittal view of anatomy, and really demonstrates all the levels that you would be going through to reach the epidural space or the spinal cord and the subarachnoid space. And so from posterior to anterior, here you see the subcutaneous fat really well, obviously, the supraspinous ligament, the interspinous ligament between the spinous processes, and the epidural fat, and then dural space, subarachnoid space, which is really bright, which shows you that we're in the T2 weighted image because the CSF is bright, and then finally the spinal cord. Okay, next slide. And then again, we already discussed this, the anatomy of the neuroforamina as seen on a sagittal view. Next slide. Again, another high yield image with all of the anatomy labeled on the axial view, where you can see the canal, the facet joints, ligamentum flavum. You can appreciate it whether or not there's facet hypertrophy on this image in this sequence. And with that, next slide, I will hand it off to my colleague, Dr. Mata.
Thank you, Dr. Samaniego. I'm Dr. Robin Mata. I'm an interventional pain fellow at Rush University Medical Center, and tonight we're going to be talking about MRI evaluation and common imaging findings. So we're going to be covering the ABCDE method. It's a systematic approach to make sure you don't miss any critical findings. So starting with A, we're looking at sagittal cuts of the lumbar spine to begin with, because sagittal balance is important. And when we lose sagittal balance, in this far left example, we see hypolordosis or straightening of the spine. We're losing the spine's ability to absorb shock. This is a chronic cause of mechanical axial low back pain, so important to notice. Compare that to another adjacent segment, spinal pathology. In the center side, we have spondylolisthesis. That's what we call when one vertebra slips on top of the other. In this image, we're looking at L5 on S1, anterolisthesis, because it's moving anteriorly. We have the Myerding classification system. That helps us grade how far forward it slipped. In this case, about 25 to 50% of that vertebra has slipped over the adjacent vertebra, so that would be a grade 2. And then if we look at the right, we see another common pathology, which is a compression fracture at the levels of L1 and L3. There can be many causes: traumatic, osteoporosis. We can also have metastasis for compression fracture. When we're talking about degenerative or osteoporotic, we are usually using the Gannett classification. So if we look at B bones, we have lytic lesions could be a cause of metastasis. Now we're going to focus a little bit more about T1 and T2 image weighting. So far left, we have a T2 image, CSF is bright. Notice the lytic lesion is also hyper intense or bright. Whether it's infection or metastasis, it will always be bright only on T2 because we have increased cellularity and edema. Compare and contrast that to another common finding, center left image. This is a hemangioma. These are usually incidental and asymptomatic. This is not lytic, and we know that because if we were to look on a T1 image, it would also be hyperintense. It is high in fat and vascularity, so it will be bright on T1 and T2, asymptomatic. Now let's look at an axial cut. Center right image. This is facet hypertrophy. Very common cause of pain. It also tells us that there's some spinal instability that's happening. And then finally, we have on the far right, we have a Schmorl's node. So this is a combination of disc desiccation as well as end plate defects, which we'll talk about later. Next slide. Cord and canal, C, important. So if you look at the far left image, we have a spinal cord, nice and hypo-intense, dark on the image. The white arrow shows a hyperintense lesion. So this is myelomalacia. Myelomalacia is important to recognize because whether acute or chronic, it will be hyperintense on a T2 image. In the acute phase, we have that edema, that cellularity rushing in. And then after it has remodeled in the chronic phase, we'll have that gliosis scar, replacing those neuronal fibers. This tells us that there is irreversible cord damage that will likely correlate with focal neurologic deficits on exam. What can cause cord pathology? Well, look at the center left image. We have a tumor that is compressing, in this case an extradural tumor, so there can be external factors that compress, but it's not only just posterior, we can also have anterior compression of the sac. So look at the image L3-4 versus L4-5. L3-4, pretty healthy spinal image here. Now, if we compare that to the thecal sac at L4-5, notice that it is scrunched. There's not that much CSF. There's clumping of the nerve roots. So anteriorly, the spine is being, the spinal canal is being compressed by a disc protrusion, in this case central, and then posteriorly, the white arrow is pointing to ligamentum flavum hypertrophy. We also have some facet hypertrophy that is adding insult to injury. Finally, in the far right image, last slide, please. We can see a sagittal cut that is showing some foraminal stenosis of the exiting nerve roots. On the top, we have a healthy nerve surrounded by CSF with a beautiful image shape. Below that, less CSF and a deranged shape. So that would be mild to moderate foraminal stenosis. And then at the bottom level, no CSF and the shape is completely distorted. So moderate to severe foraminal stenosis. Moving on to D for discs. Let's start with a normal healthy disc. Far left, disc height is maintained, bright nucleus pulposus, and we can differentiate a annulus fibrosus. Look at the center image. This is a very common image finding. So at the top, thoracic, upper lumbar, healthy discs, disc height maintained. As we descend, notice those discs are starting to desiccate, lose their water content, and they're now starting to bulge. If you fast forward that image 15, 25 years without good care, we're seeing on the far right image the end stages of advanced degenerative disc disease. Next slide. Okay, E stands for everything else. Degenerative spines are not the only cause of back pain. You don't want to miss an abdominal aortic aneurysm, like the one you see in the far left image shown by the yellow arrows. And you can also see it in the axial cut here as well. Next slide, please. Okay, for pain physicians, do not forget E, especially paraspinal musculature. Here we're talking about the multifidus. This is a key deep segmental spinal stabilizer. We know that this is independently linked with lumbar spinal stenosis, and in patients who've had prior fusion, it more than doubles the risk of adjacent segment disease. So what do you not want to see on the multifidus? Well, if you're looking at a filet mignon on your plate, you don't want to see a lot of fat. Fatty infiltration is not good. So in the acute phase, you might have a little bit of fatty infiltration, 0 to 10%, that's reversible. Once you're in that 10 to 50%, you're starting to lose a lot of muscle fibers to fat. You're going to see fibrosis. That is probably going to be very difficult to reverse. And then finally, once chronic, if this filet mignon was served you at a restaurant, you would likely return it to the kitchen. You have advanced atrophy. You know that you're going to see degenerative changes in the spine. So be looking for your multifidi muscles on axial cuts. Next slide, please. Pathologies. We're going to jump right in. Next slide. Okay, so I mentioned earlier disc degeneration staging. So here we have the Furman system for looking at this. So grade 1, young, healthy person. There is bright hyperintense signal on T2 throughout. Grade 2 is what we've kind of seen a little bit of so far. So you have that central horizontal line of low signal intensity, which is the nucleus pulposus, surrounded by the collagenous annulus fibrosus holding it inside. Grade 3, we're starting to lose that differentiation between the two, but we can still make it out. Grade 4 is very blurred, very difficult to see. We're having low signal intensity throughout. And finally, grade 5, we've lost a lot of water content. It's homogeneous low signal. We can talk about what happens once the disc is displaced in 2 different ways. Great article on PubMed, ABCs of disc degeneration, 10 out of 10 recommend. On the left, we see diffuse. So disc bulging, very common. The disc is being compressed, but it's being distributed throughout. And the disc height is preserved. Compare that to annular bulging, where the disc is being compressed, and now that disc height is no longer preserved. That's very different compared to a focal herniation. So a focal herniation, we're really stressing that outer annulus fibrosis, starting with the protrusion. So there's no or minimal annulus fibrosis disruption, but we see it pouching out at one area. Once that annulus fibrosis is disrupted, now it's extruded. The nucleus pulposus is leaking out of the disc. And then once it's separated, it's called a sequestration. For it to migrate, you also need a tear of the posterior longitudinal ligament. Next slide. We're going to see some examples of these on MRI. So here we see a bulging disc. Notice that the shape is deformed, but it's distributed evenly. Next slide. Compare that to a paracentral protrusion. So pretty good round shape overall, but there's one point that is pouching out, and in this point, it's pressing on a nerve root. Next slide. Sequestration is what we talked about. The nucleus pulposus has exited, and now it is migrating. Next slide. And here's another example of extrusion. Next slide. Okay. So we can see disc herniations and axial and sagittal views. In the sagittal plane, you just saw some examples of superior and inferior migration. More commonly, we're going to be looking at this in an axial plane. Anterior, not as common. Posterior, more common. So starting with a central. So notice if that bottom left part of the disc herniation diagram, that it is pushing back on the thecal sac and potentially the cord, depending on the level. Paracentral is going to be affecting the descending nerve root. Descending nerve root. We'll talk about that again in a second. Versus foraminal and extraforaminal, that is now affecting the exiting nerve root. Next slide. So this is a great example, okay? So here we're at the level of L4-5. Notice that L4-5, 4 is exiting, okay? But 5 is descending. So if that disc herniation is in the subarticular zone or lateral recess and is being affected by a central or paracentral disc herniation, it's that descending nerve root that is going to be affected. Next slide, please. Here's an axial view. So what is the subarticular zone? It's that large sort of triangular shaped image here. It's also referred to as the lateral recess. Disc herniations in this area will be affecting the descending nerve root versus the foraminal zone, extraforaminal zone may be affecting, likely affecting the exiting nerve root. Next slide. Okay, great example of how spondylolisthesis can cause both central canal stenosis as well as neuroforaminal or exiting nerve root stenosis. So the spondylolisthesis here, we can see on the far left, that cord is being pinched, it's being compressed. And then if we look at it from a neuroforaminal standpoint, same thing, little CSF and that exiting nerve root is being deranged. Next slide. Degenerative end plate changes are important to talk about because it's a reaction to degeneration of the discs. Here we're talking about the modic type changes. People are familiar with type 1 through 3. There's a modic Thompson classification that goes out to type 6, which is what you see on this slide. So type 1, healthy individual, normal end plate, no interruptions, solid line of contour above and below. Type 2, that end plate starts thinning, but we don't see any defects yet. Type 3, now you're starting to see some cracks in the armor, but they're very small and overall you can still make out the lead. Type 4, 5, and 6, now we're talking about Schmorl's nodes. So type 4, you've got those end plate defects, but it's less than 25%. Type 5, 50%. And type 6, when it looks painful on x-ray, is likely type 6 end stages degeneration. Next slide. Okay, so if you go deep into the article here, talking about type 1A, type 2D, and type 3G, it's what people commonly think of when they think of type 1, 2, and 3 motor changes. So let's talk about what you need to remember. So on type 1, this is the acute phases of degeneration in the vertebral bodies, or the end plates specifically. We're seeing an influx of cellularity and edema, inflammation. That is going to be hypo on T1, it's not fat, and it's going to be hyper on T2. So hypo T1, hyper T2. Compare that to type 2 mode of change. Now we're seeing fatty infiltration, okay? Think about it as like a more subacute phase. That is going to be both hyper intense on T1 because of the fatty infiltration, and the increased cellularity will also be hyper intense on T2. So both T1, T2, type 2. And then finally, we have our type 3, where the bony end plates are being replaced with sclerosis. That is going to be hypo on both T1 and T2. Next slide, please. And finally, we have our buffet of spondylosis changes. We've touched on all these topics so far. The only one to mention here so far is cysts. So if you look at this central image at the top, we have a synovial cyst that appears to be contiguous with the articular area of this facet joint. All of these changes of degeneration are important to notice on MRI, and my colleague, Dr. Italiano, will be speaking more about the relevance of this.
Thank you, Dr. Mata. I'm Jordan Italiano. I'm one of the chronic pain fellows at Cleveland Clinic, and I'm going to discuss spinal stenosis. So spinal stenosis is one of the most common pathologies we run into as pain physicians. There's roughly 1.2 million people that are diagnosed with stenosis in the US each year, and about 14 million patients in the US have symptomatic lumbar spinal stenosis. So approach to treatment can be multimodal and usually varies from conservative approach with PT and medications to what we can typically offer as pain physicians with injections. And there's 1.5 million epidural steroid injections administered each year. But as we're all well aware, this provides only temporary relief. A more definitive approach would be surgery. There's over 175,000 decompressive surgeries performed each year, and lumbar spinal stenosis is the #1 reason for spine surgery in the elderly. Next slide, please. So lumbar spinal stenosis occurs when the space within the spinal canal or around the nerve roots become narrowed. Lumbar spinal stenosis can occur in various areas of the anatomy, and we typically consider 3 areas of where that narrowing happens. So we have the central canal, the lateral recess, and the foramen. So if we look at this image on the left here, between the blue lines is what we call the central canal. This is the spinal canal's main channel. When narrowing occurs here, it puts pressure on the spinal cord itself, or the cauda equina. If we go a little more laterally, outlined by those green dotted lines, this is the lateral recess, or the subarticular zone. It's located between the medial margins of the facets and the medial margins of the pedicle. This is inside the spinal canal where the nerve root travels before exiting the spinal column. And then even further laterally, outlined by those black dotted lines, is the foramen. Stenosis here leads to narrowing of the intervertebral foramen where the nerve root exits the spine. And we'll get more into this later, but the symptoms and presentation will vary depending on the location of the stenosis. So now let's look at spinal stenosis in terms of MRI classification. So when looking at MRI, we can define stenosis based on measurements of the spinal canal in both the axial and sagittal views. So a normal spinal canal width would be greater than 15 to 23 millimeters in the AP diameter. Stenosis would be defined as less than 12. When we look at axial cuts, we now want to look at the spinal canal area. Normal would be greater than 100, and stenosis would be defined as less than 70 to 90 millimeters. So if you look at this image on the right, in image A, we have a T2 sagittal view. We can see varying degrees of stenosis in the lumbar spine when looking at the AP diameters. Visually, without any need to measure, you can visualize that the greatest stenosis occurs between L3-4 and L4-5. And this is supported by the smallest AP diameters and measurements. If you look at L3 and 4, it's about 7.5. L4-5 is about 8.5, compared to about 11 or 12 through all the other levels. Now let's look at the axial cuts here. So B, C, D, E, and F, all axial cuts. You can see that B, C, and F all look pretty open. You have an open central canal. There's no obliteration of the CSF anteriorly. You have an open lateral recess and open foramen. If we were to look here, this would be supported by a spinal canal area of greater than 100. And you can see, I don't know if you can quite visualize it, but all those areas are greater than 100, ranging from about 117 to about 137. Now, looking at D and E is a slightly different story. If we could go back, thank you. So there's more stenosis here. You can see some obliteration of the anterior CSF. In D, you have that obliteration of the CSF space, but you can still see the rootlets of the cauda equina separate. It looks like there's some narrowing of the lateral recess as well. And then E, you have that more severe stenosis. The nerve rootlets of the cauda equina are starting to aggregate, and this is supported by the lowest area on measurement with an area of about 60. Next slide, please. So if we look at figure A, this is a normal central canal. Once again, a wide open canal, wide open lateral recess and foramen. This would have an area of a greater than 100. As you can see, there's clear separation in the cauda equina, no obliteration of the CSF. You see a completely different picture in B. You see a severely stenosed canal indicating severe spinal stenosis. So spinal stenosis can be caused by many different mechanisms, and it's often a combination of different pathologies. So if we think of the spinal canal as a circle, we have both bony and soft tissue structures surrounding it. Along the anterior side, we have disc and vertebral bodies. Posteriorly, we have the ligamentum flavum, and laterally on each side, we have the facets. So if we have pathology to any of these structures, it can contribute to narrowing of the canal. So if we look at C, D, and E here, you can see C, that red line indicating a disc herniation, that green line in B outlining a thickened ligamentum flavum, and that yellow arrow in E pointing to an inflamed arthritic facet joint. So a combination of any of these pathologies can contribute to spinal stenosis. Next slide, please. So let's look at some causes. So if we think congenitally of what can cause spinal stenosis, we typically think of short and thick pedicles. So short pedicles will actually lead to a decreased AP diameter of the spinal canal and essentially lead to an increased risk of symptomatic lumbar spinal stenosis. The same thing would occur with thick pedicles. Instead, the thickness of the pedicle will actually decrease the spinal canal area. And one study actually showed that pedicle thickness was associated with a higher possibility of lumbar spinal stenosis. And you can see in this image on the right here, that pedicle on the left measures close to 10 millimeters compared to that pedicle in the right image, which is about 12. And you can see how just that little bit of extra thickness can cause an increased narrowing along the canal. So degenerative changes can also lead to stenosis. So we have the wear and tear of the lumbar spine. It leads to arthritic changes, osteophyte formation, disc herniations, thickened ligaments. This is all what I kind of talked about previously. All of those pathologies can lead to an increased risk of stenosis. We have acquired causes as well, things such as disc herniations, spondylolisthesis, infection, discitis, tumors, and metastatic disease. If we look at this image, we have a T2 sagittal view down at the bottom left here. You can see that yellow arrow pointing to a hypo, dark, intense space within the vertebral body. This is most likely indicative of a tumor or some other type of metastatic process. And while this can lead to spinal stenosis, we always want to make sure that there's further investigation with MRI with contrast. Next slide, please. So this slide is going to kind of focus on the degenerative cascade of the lumbar spine and how this can lead and contribute to spinal stenosis. So if we look at this picture on the left here, we have a normal disc that's well hydrated, spongy. It acts as a cushion or shock absorber, and it helps support lumbar spine movement. Now, as we age, these discs start to dry out, they become desiccated, they lose their sponginess, they become increasingly stiff and flat, all leading to a loss of disc height. Now, as the disc continues to flatten and we continue to have wear and tear on the spine, the annulus fibrosis can tear, leading to disc pain, disc bulging, local inflammation. These changes in the disc and the spine can lead to loss of lumbar spine movement and motion. The spine can actually become more unstable, especially if the nucleus pulposus starts to protrude through those small annular tears. Finally, the spinal segment attempts to become more stable as bone spurs and osteophytes form. And these osteophytes change the normal mechanics and stress on the spine, and it creates an increased load and pressure on the facet and ligaments. And with all these changes between the osteophytes, the disc bulges, and the stress on the joints, it can cause impingement on the spinal cord and or nerve roots. Next slide, please. So now let's look at this here on the top image, figure A. This is essentially a normal spine. We have a normal, well-hydrated spongy disc, an open foramen without any facet changes, and this correlates to a clean, open canal on MRI in figure A. As we go down to the next image, we already kind of stated, as you age with normal wear and tear, the disc will begin to dry out. It loses its shock absorbing capacity. As this continues to happen, there's increased risk of annular tears and disc bulging. And as you can see, this correlates to some compression on the anterior CSF with some slight narrowing of the canal in image B. Next slide, please. So at the top here, we see further degeneration of the disc. It can cause extrusion, once again, putting more pressure on the canal. In figure D here, we have that disc space continues to narrow. It puts more stress on the joints and ligaments, which you can see can lead to facet arthritis and ligamentum hypertrophy, as already discussed, all of which can contribute to significant degree of stenosis. And then finally in figure E here, we just have that continued wear and tear causing vertebral degeneration, spondylosis, osteophyte formation, and facet arthritis. Next slide, please. So as mentioned earlier, the location of the narrowing can change the presentation. So with central canal stenosis, this is the most typical presentation. This is what we read about in textbooks in medical school. It can present with back, buttock, and or leg pain with neurogenic claudication. So the pain will worsen with prolonged walking and standing. The patient will typically get immediate relief with sitting and rest. The pain is positional, so it will worsen with extension as this causes more narrowing of the canal, and it will improve with flexion. Patients will often present with a positive shopping cart sign, and depending on the severity of the compression on the canal, some patients may have possible weakness. As we go to lateral recess stenosis, this will also present with neurogenic claudication, but the pain will tend to be more radicular. You can have pain in the back radiating down one or both extremities. Weakness can be present, but it is often more rare. And then in the foramen with stenosis here, you still have that neurogenic claudication picture, still radicular pain. You have pain that worsens with movement, eases with rest. However, now you can have paresthesias tend to be present, but both the pain and paresthesias tend to be more dermatomal, and this is due to narrowing around a specific nerve root. Next slide, please. Now I want to get into the grading system of spinal stenosis. So there's several different grading systems. Here, this image on the top, this is the Lee grading system. It's a 4-grade classification system of lumbar spinal stenosis, and it's based on the obliteration of the CSF in front of the cauda equina using T2 imaging. So we can look here at this image. There's essentially 4 grades, grade 0, 1, 2, and 3, correlating with normal, mild, moderate, and severe. So we see a normal, if we're just looking at central canal stenosis, we see grade 0 as normal. Grade 1 would be mild, which would just show some anterior CSF obliteration. It's mildly obliterated, but the nerves in the cauda equina are still clearly separated. As we get to grade 2, those nerves in the cauda equina start to aggregate. And finally, in the severe form, the entire cauda equina just appears as a bundle. When we're in the lateral recess, grade 1, you would have narrowing of the lateral recess without root flattening. And as we get to moderate, you have narrowing of the lateral recess with flattening of the root, but there's still some preservation of the CSF space. And then in grade 3 or severe, you have severe root compression and essentially complete obliteration of the CSF space surrounding it. And then finally, foraminal is more so graded on the percent of stenosis. So mild or grade 1 would be less than 50% stenosis. Grade 2 or moderate would be greater than 50% stenosis. And then grade 3 would be severe foraminal stenosis with a complete nerve root collapse. And then the bottom grading system is the SCISAD grading system here. It's a 7-grade classification of lumbar spinal stenosis based on morphology of the dural sac and the ratio of the rootlets to the CSF on T2 imaging. So grade A is no or minor stenosis. You have the CSF that's clearly visible. A1 through 4 essentially varies on where the rootlets lie and how much of the dural sac it occupies. So A1, the rootlets lie dorsally and it occupies less than half of the dural sac. A2, the rootlets lie dorsally, but it's in contact with the dura in a horseshoe configuration. A3, the rootlets lie dorsally, but it occupies more than half of the dural sac. And then A4, the rootlets lie centrally, occupying more than half the dural sac. Grade B is moderate stenosis. It's where the rootlets occupy the whole dural sac, but they can still be individualized. CSF is still present. It kind of gives a grainy appearance to the sac. And C is severe stenosis. It's where no rootlets are recognized, no CSF is visible, but you still have that epidural fat remaining posteriorly. And then in the extreme case of stenosis, which would be grade D, that's in addition to no rootlets or CSF being recognized, the epidural fat is obliterated posteriorly. Next slide, please. So now I'm going to talk about vertebral compression fractures. So it's a major cause of severe back pain in elderly patients, especially in osteoporotic women. It's most commonly related to osteoporosis and trauma. It can present with acute onset of pain, and it can compromise mobility and quality of life. It causes vertebral body height loss, and the decrease most commonly occurs along the anterior column. Next slide, please. So what is the vertebral compression fracture? It's essentially just the fracture of the vertebral body leading to loss of vertebral body height. We typically use the Ganot semi-quantitative grading system, and that essentially measures the degree based on loss of vertebral body height. So mild would be loss of 20 to 25% vertebral body height, moderate would be 25 to 40%, and severe would be greater than 40. The most common cause is osteoporosis, but other causes can be from infection, malignancy, or trauma. The best initial modality to diagnose compression fractures is CT. However, to determine between acute and chronic fractures, an MRI is needed. Looking at the epidemiology, there's about 700,000 vertebral compression fractures annually in the US. The most common locations are between T12 and L2. In fact, 75% of all compression fractures occur between this level. There are several different types of compression fractures. So we have wedge, which is the most common. It accounts for 50% of all fractures. It's when the front part of the vertebrae collapses, creating a wedge shape. And you can see that in the image in the top right, and you can see how it varies with the degree between mild, moderate, and severe. We have bioconcave, which accounts for 17% of vertebral compression fractures. It's when both the front and back part of the vertebrae collapse inward, forming a concave shape between the upper and lower end plates. And finally, we have burst or compression, which accounts for 13% of compression fractures. And it's when the vertebrae breaks into several fragments and may press against the spinal cord and or nerves. Next slide, please. Now getting into risk factors, age is a common one. So as you get older, the risk increases. 50% of people over the age of 80 have one vertebral compression fracture. It's more common in women. It occurs 10.7 per 1,000 women compared to 5.7 per 1,000 men. And then essentially anything that puts you at an increased risk of osteoporosis puts you at an increased risk of vertebral compression fractures. So early menopause, you have the early loss of estrogen, you have increased osteoclasts, increased bone resorption, leading to increased loss of bone density. Tobacco and alcohol all lead to increased risk of osteoporosis and compression fractures, low calcium, vitamin D. And then finally, a prior vertebral compression fracture increases your risk by 5 times to have another one. Next slide, please. As briefly discussed earlier, the MRI is used to differentiate acute versus chronic compression fractures. So a hyperintensity or bright spot on STIR and T2 and hypointensity on T1 represents the edematous changes of an acute compression fracture. Once the fracture starts to become chronic, you lack that hyperintensity on STIR or T2, and the marrow starts to appear normal. So if we look at these images here, these are all T2 sagittal views of the lumbar spine and more into the thoracic as well. But you can see the arrow in the middle image indicating that hyperintense white vertebral body. The image on the right, you can see that white hyperintense vertebral body at L3, all indicating acute compression fractures. Next slide, please. So this image here, this is a T1 sagittal view. CSF is dark. You can see the hypointense darkness of the L3 vertebral body. Once again, this is just representing an acute compression fracture of L3 on a T1 image. Next slide, please. And this is showing an acute compression fracture on a T2 sagittal view. You can see the hypertensity of the L3 vertebral body. Next slide, please. And then finally, we just have an axial view of the compression fracture. You can see the clear fracture line on the right side of the vertebral body. Thank you.
All right. I want to ask our panelists to come back on camera, and I want to thank them for giving a very excellent presentation. This is a time frame in our webinar. We're going to open it up for questions, and so if anyone has any questions, you can type your question into the chat box, and it'll be sent to us directly for us to address. I'd like to toss out the first question to Dr. Samaniego. In your earlier PowerPoint slide, you had the sagittal view that showed some dashed lines on the thickness of what a typical MRI slice was, being 4 millimeters in thickness. Is there times when we can get less thick or thinner slices, and what would be the indication for us to do so?
So off the top of my head, I do know that when you need to evaluate for a suspected dural puncture or CSF leak, that you can get thinner slices, I believe as thin as 1 millimeter. But in that case, because that would be so many images and slices that you would take, if you have a suspected level where you think that dural puncture would be, then you would request having those thinner slices at that vertebral body level.
All right, Dr. Pak or Dr. Ibrahim, do you have any questions for our panelists?
Sure, I'll give one to Dr. Mata. Great job on talking about, among other things, paraspinal and specific multifidus fatty infiltration. And I think that the steak analogy is a really good one because I think that's something that we can all relate to. Can you talk a little bit more about the clinical significance of this particular finding? Because it's something I know during my fellowship I was not told to pay attention to.
Yeah, absolutely. So the multifidus is probably one of the most important muscles that we've never heard of. It's a really deep spinal muscle, important for segmental stability. Basically, while the vertebral bodies are moving, they're stabilizing at those intervals. So when that fatty atrophy is occurring, those muscle fibers that are responsible for stabilizing your spine while you're moving are being replaced with non-contractile fat. And that usually happens after a sort of protective shutdown signal from the brain after a back injury. But we know that this is a major predictor of chronic recurrent back pain because now the spine has lost its primary internal support system. So we're going to see a lot of joint micro instability happening. And unlike general muscle weakness, that fatty atrophy usually is going to require targeted neuromuscular retraining to address the issue, because once you have a high level of fatty infiltration, those muscle fibers are lost.
Thank you. I think those are great points, especially because I know even within the spine surgery community now they're all trying to do multifidus sparing surgery. So I think that highlights it really well. Dr. Ibrahim?
Yes, great job to all the panelists. Dr. Italiano, my question is for you. You did a great job discussing vertebral compression fractures. What would you look for on MRI that would preclude you from choosing vertebral augmentation as a therapy for these patients?
Yeah, so I think it's important when reviewing MRIs, there's a couple of things you want to look at before pursuing vertebral augmentation. One would be like any evidence of spinal instability. Obviously, we would prioritize anything that would require surgical fixation over a cement augmentation. You also want to consider burst fractures or any other fractures with retropulsed bone fragments. You want to consider vertebral compression fractures where there's complete disruption or a significant breach of the posterior wall of the vertebral body. All of these types of fractures are essentially jeopardizing the neural structures. And then any case where there's any neurological compression or evidence of myelopathy. There's some more relative contraindications as well. If there's a severe vertebral body height collapse of greater than 75%, the efficacy of vertebral augmentation and returning that disc height would not be as significant. Some other things too could be the potential for damaged pedicles. Not only would it make the transpedicular approach more difficult, but it would also raise the concern about proper cement containment.
All right, we have another question that's written in from our audience. I'll ask Dr. Italiano to address it. And the question is, what does an acute compression fracture look like on T1 versus T2? So could you go through that again so we can differentiate the acute compression fracture on the T1 and the T2 image?
Absolutely. So on MRI, an acute compression fracture, you're looking for those edematous changes within the vertebral body. So on T2 and or STIR, you're going to see a hyperintensity or bright structure within the vertebral body. And then on T1, you'll see that hypointensity or darkness within the vertebral body.
All right, excellent. If there's any other questions, please write them in and we can address them. I want to thank all of our panelists here. Throughout our webinar tonight, we've addressed a few things here. We've first discussed some of the mechanics of what generates an MRI image and how to properly represent that on your computer screen so you can interpret it. We then also addressed some of the disc-related abnormalities that happen in degenerative disc disease and what they look like on MRI. We've also discussed the bony abnormalities and how those relate to the degenerative process. So we have one more question that's coming here. In some patients with anatomical variation, such as scoliosis, sometimes it is hard to assess the degree of spinal or foraminal stenosis. And so are there any specific considerations to keep in mind when you're trying to assess the degree of stenosis in the presence of scoliosis? So I'll throw that to any of our panelists here. How do you go about addressing that scoliotic spine? And how do you look at that differently than somebody who's got a typically normal straight spine?
I can take that question. So when there's scoliosis, if you're looking at stenosis specifically, you're going to want to correct for vertebral rotation. So the standard axial MRI slices are usually cut obliquely across the anatomy, so that can underestimate the true degree of narrowing. You really want to pay attention to the concave side of the curve, or the C, inner part of the C. That's where the physical collapse of the foramen is happening, and we're seeing some more thickening of the ligaments and flavins. So you can see a lot of severe, I think they call it guillotining, compression of the nerve roots. So it can also be dynamic. So you're probably going to want to get some weight-bearing X-rays or even like a CT myelogram, just to reveal some of that foraminal closure that can occur when the patient is upright.
And I'll throw in an extra little tidbit of advice. Sometimes it's useful to look at plain lumbar spine films or the FlexX lumbar spine films immediately before looking at the MRI to kind of give you a idea of what some of the depth of abnormality is that you're dealing with. And so it can kind of facilitate your understanding what's going on at the MRI level. I want to thank our panelists and our my co-moderators for participating in tonight. We have a couple of other educational events coming up within the Aspen organization. The first one is going to be the Aspen Super Bowl debates. This is an annual exercise. It's going to be held on January 8th this year. And so tune in for that. That'll be our very next one coming up in about a month. And then the second event I want to remind everybody is the Aspen Annual Conference in July of 2026. The ability to submit some abstracts just opened up. So if anybody is interested in presenting abstracts, the abstract time opening just occurred. And so now is the time to start getting those in. And so with that, I'd like to thank each one of us for participating. I want to thank the audience for their kind participation here. and wish everybody happy holidays, Merry Christmas, and a Happy New Year. And then we will see you back again in January. Thank you.